Primary adrenal insufficiency and its resulting adrenal crises are life-threatening conditions often presenting with hypotension, hyponatremia, hyperkalemia, and hypoglycemia due to relative glucocorticoid and mineralocorticoid deficiency. Typically, replacement therapy with physiologic doses of glucocorticoids and mineralocorticoids can manage symptoms. However, treatment-refractory cases present a significant challenge. This case highlights a unique treatment option for a patient refractory to usual oral steroid doses. We present a 7-year-old woman with a 15-year history of Addison's disease. She had multiple hospitalizations for symptoms including abdominal pain, myalgias, dizziness, nausea, vomiting, and diarrhea. During this time, she was also febrile, hypotensive, and tachycardic. Her presentations were concerning for recurrent adrenal crises. Her medical history included recent chronic UTIs on prophylactic nitrofurantoin and D-mannose, borderline IgG deficiency, anemia, and hypothyroidism. For more than a decade, she was stable on oral hydrocortisone at 10 milligrams in the morning and fludrocortisone at 0.2 milligrams daily until 2 years ago when she started to have an increase in frequency of adrenal crises, and particularly more frequent in the past 2 months. Across her 5 inpatient admissions, she required progressively higher doses of steroids. We completed oral hydrocortisone absorption testing with an understanding that absorption is dynamic and may not be entirely accurate. This testing at the time showed an appropriate response. With this in mind, on a later admission, she was transitioned to intramuscular hydrocortisone, but continued to have symptoms. On her 5th admission, results confirmed rapid hydrocortisone clearance. As seen in the graph, even at high doses of IV hydrocortisone, the patient's level of cortisol varied greatly, even reaching as low as 4.3 micrograms per deciliter. The graph highlights that the patient required significantly high doses of hydrocortisone to not only achieve adequate cortisol levels, but also prevent intense symptoms like myalgias, arthralgias, and fatigue. Given the inadequacy of both oral and intramuscular hydrocortisone therapy while the patient was at home, we implemented a continuous subcutaneous hydrocortisone infusion via a Medtronic insulin pump. Initially, the patient was managed with a stress dose of 100 milligrams per day via the pump. She was later stabilized on an intermediate dose of 73 milligrams per day, which effectively controlled her symptoms and somewhat stabilized her cortisol levels by labs. This case highlights the critical importance of recognizing poor oral absorption of hydrocortisone or rapid steroid metabolism as a contributor to treatment-refractory PAI. In our patient, there was evidence of rapid steroid metabolism necessitating higher doses of steroids to achieve symptom control. Various genetic factors may be contributing. For example, glucocorticoid receptor gene polymorphisms and mutations have been associated with altering glucocorticoid sensitivity and impairing various steps of steroid signaling, resulting in resistance. The onset of treatment resistance after more than a decade of being well controlled on oral steroids in this patient may be related to a combination of genetic, environmental, and social factors. For one, age-related changes such as decreased activity of 11-beta-hydroxysteroid dehydrogenase 2 and increased activity of 11-beta-hydroxysteroid dehydrogenase 1 can lead to variations in cortisol clearance and tissue sensitivity. This patient had also been complaining of chronic dysuria and urgency during the times of her adrenal crises, though true UTIs were only diagnosed on 2 out of 5 of the total admissions. The urinary tract infections coupled with her borderline low IVIG may hint towards a chronic subclinical infection that may not have been detected on infectious workup but could have contributed to alterations in steroid metabolism and recurrent adrenal crises. It may also be true that after we transitioned the patient to intramuscular hydrocortisone at home, she was poorly compliant in the outpatient setting because of difficulty in giving herself the injections. Therefore, the cause is more likely to be multifactorial. Regardless of the underlying etiology of treatment resistance, the delivery of continuous subcutaneous hydrocortisone via the Medtronic pump, which is classically used for insulin delivery in diabetic patients, proved to be a necessary tool for managing our patient's primary adrenal insufficiency. For one, the pump was able to deliver significantly higher doses of daily steroids tailored to addressing times in the day that the patient would have worsening symptoms. In doing so, we were able to better mimic the physiological circadian rhythm and pulsatile secretion of cortisol. The pump is easy for patients to use after training. It may also improve compliance. Furthermore, the ability to adjust doses appropriately in response to symptoms at home makes it more suitable for certain patients. For our patient, the pump was not merely an alternative means of therapy, but an essential intervention to achieve stable hormone levels, improve quality of life through symptom control, and prevent recurrent adrenal crises and hospitalizations.